The goal today is to finish up this chapter. That will be the end of the material for exam 3. The study guide is up to date and the learning path has just been made active today for exam 3, so I just wanted to remind you guys of that. Somebody is watching both lectures, Monday, Wednesday, Friday, and Tuesday, Thursday lecture, and made a comment that my notes in this class about the nasopharynx and the oropharynx, I put that the nasal cavity is anterior to the oropharynx. That's what the parentheses mean in this. And then I also said the nasopharynx is posterior to the nasal cavity in Tuesday, Thursday lecture. And then so they said, and when you say anterior and the other say you posterior, I said, well, you have to listen to the lecture to know what I'm saying anterior and posterior to. So do be aware that sometimes some people, I do know, just read the notes that are put up, but if you don't listen to the lectures, sometimes you get confused as to what is in what location. Just a minor point. So now we're into the thoracic pressure relationship diagram, and it's important that you guys understand that when the volume increases in the thoracic cavity, the pressure decreases and vice versa. So there is indeed an inverse relationship to volume and pressure in our thoracic cavity. Now let's take a look at surface tension. Surface tension is one of the major factors besides the negative pressure in the thoracic cavity that helps to keep our lungs inflated and abutted up against the thoracic cavity wall internally. There are no connective tissue connections between our lungs and the cavity wall that it resides in, just a thin amount of serous fluid, which is also known as pleural fluid, and it is predominantly water. And so we know water is polar, and that's what gives water a high surface tension. So water has a nice surface structure whenever it's laid out in a lake and you fall down on it. It doesn't always feel so good if you've been water skiing and going pretty fast. So it's that surface tension, that polarity of those water molecules that are there that help to keep things together. The other thing too is realize that the serosa, or the pleural surfaces, are like what I call saran wrap. And so if you put water between two pieces of saran wrap, how easy is it to get it apart? It's a lot of work. It's very difficult. You know, you take your wet glass and you put it on a coaster and then you pick it up, and often you will pick up the coaster. So this surface tension is a very important factor in keeping our lungs applied to the cavity wall itself. Something that's working against this expansion of the lungs is what's called elastic recoil. The lungs are really very elastic in their tissue construction, and it's very nice. They are really stretchy, so we can blow them up just like a balloon. But they do the elastic tissue has that thing which will work against our lung expansion, and that's called recoil. So that elasticity of that tissue works against us with that recoil factor. The other thing is, so our lungs, if they're not inflated, they naturally want to collapse, and that would be to pull away from the wall and not hold air well. The other thing to keep in mind too is that also will contribute a little bit to that negative pressure is our thoracic wall actually wants to spring open. If you did not have your sternum intact, and often whenever we do coronary artery bypass surgery, we have to cut through the sternum to get to the heart, the chest wall springs open. And so you have the springiness of the chest wall trying to actually expand, and you have a factor of the lung tissue trying to collapse inside. So those two elastic forces are almost opposing elastic forces. I was waiting for that to come up. So we have the elastic recoil of the lung tissue trying to shrink or pull away from the thoracic wall, and we also have the thoracic wall springiness springs away from the cavity. in which it actually even creates. So it wants to expand outward. Which in essence would be almost like increasing the cavity volume. It's the natural way it wants to do that. Pleural pressure, very key, always less than atmospheric pressure when inhaling. You notice it's very specific as to what maneuver you're doing. Pleural pressure is also known as intrapleural pressure. So we get sometimes lazy and we drop certain words. So pleural pressure is the same thing as intrapleural pressure. And it is less than atmospheric pressure when inhaling. So what that means that when we inhale and our diaphragm flattens, we're increasing the volume of the thoracic cavity and decreasing the pressure, and that will pull the lung tissue along with it. Because when we decrease the pressure inside the thoracic cavity and we have this balloon suspended, and I forgot to get my little diaphragm glass bell. Have you guys all seen that in lab? Has it been demonstrated? So you have to, with that, it's designed to help you to understand when you have a closed space and you put in something that's connected to the outside space, which is our airways, are connected to the outside space, and you suspend that into a closed space, and then you actually increase the volume and therefore decrease the pressure in that space. That impact is generated all the way to the level of the lung tissue itself, and it's generating all the way to the air inside the balloons or our alveoli. And so when we create a negative pressure around that, that is actually felt by that tissue, it's experienced by that, and so it causes air to be pulled in. Because air will move from an area of high pressure to an area of low pressure. And those balloons are suspended in a low pressure area connected to the outside world, and they will actually transmit that experience to their own contents. Are you guys kind of following me with that a little bit? And so that's why it's really important to actually visually see that, because I can explain it, and you look at me and you go, I hear you, but I don't really understand it. And when you actually see it and how it's transmitted to springy, elastic tissue, you can actually appreciate the expansion that actually occurs. So intrapleural pressure, always less than atmospheric pressure when inhaling, so air will move in. Let me ask you about the pressure when we exhale. In order to push the air out, what is the pressure differential on the outside of us versus on the inside of us in order to push air out? It's higher inside us, correct? And so at that time, that intrapleural pressure is also higher because we've shrunken the size of that area, because the diaphragm goes up and the volume goes down and the pressure goes up. And so even then, the pleural pressure now has to change to where it's greater, and that is transmitted to the lung tissue itself, the inside of the lung tissue, and that pushes the air out. Now, is that intrapleural pressure greater, so great that it causes the lungs to actually collapse? In other words, not be applied to the wall of the cavity. It is not. So it's never greater to the extent that we will actually then cause complete lung collapse. It's just enough to push the air inside the spaces inside that area out of the body. A couple of things I want to add down here too for the intrapleural pressure notes is pleural differential, pleural pressure differential, plus surface tension is going to be greater than elastic recoil of the lungs and the cavity. What this means is that's This is what's keeping our lungs expanded or inflated. We have surface tension, we have this pressure differential that is going to keep our lungs applied to the wall. When our lungs naturally want to collapse, if we do not have enough of factors in favor of this. And so one of the things that's important for you to realize is that we have a serosal surface on the outer aspect of our lungs. It's called visceral pleura. We have a serosal surface on the inside of the cavity. It's called parietal pleura. And what would happen to the lung suspended in that cavity, say the right side, if the visceral pleura got a tear on it? It would what? If we tore the visceral pleura, what would happen to that lung that's in that cavity? Would it stay inflated? What would happen? It would collapse. Right. Remember back to the balloon. I'm basically asking you to transfer this little question back to what you visually saw with the balloon in the belt chamber. If you put a hole in the balloon, is it going to expand? No. And so what you're used to probably thinking about as holes and invasion of the pleural cavity is somebody with a stab wound from the outside, correct? Where the parietal pleura is actually torn. And that does happen. The parietal pleura will get torn with a knife stab wound, and then the lung will collapse because we no longer have that negative pressure in there. And remember, the lungs want to actually collapse it if you'll let them because of that elastic recoil. So the surface tension and the negative pressure keeps things inflated as long as everything's intact. But if you break a serosal surface, pleural, parietal, or visceral, you will end up with actually a collapsed lung. What if you impacted surface tension? What if we decreased surface tension? What do you think would happen if we actually decreased surface tension? You can do that putting in like a detergent, a soapy material. What would happen? It wouldn't stick to the wall, so then that also would cause the lung collapse. So there's surface tension, and that negative pressure is very important to keeping the lungs properly expanded. Spontaneous pneumothorax is actually where there's a tear in the visceral pleura. And that means that now we have our balloon has got a hole in it, and now we cannot keep the lung inflated. And so the treatment for that is, does anybody know how they treat a pneumothorax? They stick a tube into that thoracic cavity, and they hook it up to a pump. And does the pump put air in, or does the pump pull air out? If you put air into the cavity, will that expand your lung? Yes. It will be air around the lung, but that's not expanding the lung. So what do you want to do? Do you want to put air in, or do you want to pull air out? You pull it out. You want to create that negative number again, because when you create that negative pressure, then we are getting closer and closer to the whole lung then fitting into that negative cavity with the surface tension. And so that's actually what they do with the pneumothorax. They actually put a chest tube in and they hook it up to a vacuum, and it sucks air out, and gradually they're able to get enough air sucked out, and the leak seals off, because you're sucking air out and it doesn't work until the leak seals off, correct? And so the leak seals off, and then you are able to then suck enough air out to where we get our negative pressure. Lung expands, fits in the area, and the person's feeling a lot better when they can actually breathe with two lungs. So those are some of the things that can actually happen to our lungs when they are not properly inflated. Let's look at the terms pulmonary ventilation here. Inspiration is inhalation, and indeed the diaphragm will contract moving downward, therefore increasing the thoracic volume. And remember, volume to pressure relationship is inverse. Increased volume means decreased pressure. Decreased volume means increased pressure. And that's how we get air to move in and out. Diaphragm contracts, increases the top to bottom dimension for your thorax. And then when we also have an additional muscle that works when we inhale, the external intercostal, so they're in between our ribs, and they will actually contract and they will actually bring our rib cage up, so we'll increase our anterior and posterior diameter, as well as there's going to be a lateral expansion too for you, and you can actually feel that when you put your hands around your chest and you take a big breath in. You can feel the increase in anterior, posterior, as well as lateral dimensions. So all of these things together work to increase the volume, therefore decrease the pressure, and air will then rush in. You will hear me often say that we suck air in, and that's because it's a negative pressure. And suction to me is kind of a negative pressure phenomenon. So we suck air in and we passively push air out, because expiration actually is a passive process. We just relax the muscles and they slowly go into their relaxed position, which decreases our thoracic volume and therefore pushes air out. If we want to actually forcefully blow something up, we will use internal intercostals and our abdominal muscles will contract. And what this is doing for us, this is actually pulling our rib cage down, decreasing the volume. In a forceful fashion, so we actually can push air out. The passive action is actually a much slower process, and typically exhalation is actually a slower process, a natural exhalation. Things influencing ventilation, lung compliance, lung elasticity, and alveolar surface tension now. So moving air in and out. Ventilation is a physical action of moving air in and out. Lung compliance. Our notes here say the ease with which the lungs can be expanded. Then we have lung elasticity, and it says it's the opposite of compliance because this is with recoil here. So the ease with which lungs can be expanded. Let's show you what I mean by compliance and also elasticity. All right, you have a balloon. And you have two of them. One you've blown up several times and the other one hasn't been blown up yet. Which one has the best compliance? The one you've blown up several times. It's already been stretched out and already experienced an increased volume inside, and so the compliance is easy on that. What about a brown paper sack? What about its compliance? You can take a brown paper sack, put it to your mouth and blow it up, and doesn't it have great compliance? Yeah, that's got even better compliance than a balloon. But what about elasticity for the paper sack, for recoil? Yeah, it's really bad, and so it's actually harder. The nice thing about recoil of our lungs, it does help us to exhale. It helps us to get the air out. The balloon that is very stiff is really interesting because it also has decreased compliance, and that's a situation where you see with lung fibrosis. Can you imagine if your nice elastic lungs became kind of fibrotic and scarred? What would happen to your compliance then? Be very difficult to bring air in because of the compliance factor. But the other one, the brown paper sack, that belongs to somebody with emphysema. Those people have COPD or emphysema, have the brown paper sack. They have this lovely compliance, but they don't have the elasticity. And so what you typically see with people who have emphysema or COPD for a long period of time, that you've actually seen that their chest gets even more barrel-like in those individuals because they've lost the elasticity, which actually kind of also, the lungs kind of springing back inside keeps that barrel chest from actually happening. So lung compliance is going to be affected by scar tissue. It's going to decrease lung compliance. It's also going to be affected by airway blockage. when people have bad asthma or an infection, for example, and let's see, ease with which lungs can be expanded. Anything else? Those are the two main things for right now, airway blockage and scar tissue. Elasticity, that's opposite of compliance. We want our lungs to actually have the recoil factor. It's good for us to get the air moving in as well as out. Alveolar surface tension. Previously we were talking about pleural surface tension. So when I talk about alveolar surface tension, I'm talking about inside our little balloons. So one of the things that everybody knows is that when you want to clean your glasses or want to clean a glass surface that's mobile and stuff like that, you can bring it up to your mouth and you go, so that means you get steam on them to use to clean them, and steam is water. So one of the things that's important for you to realize, you have water inside your airways. You have water on the outside of the airways, and you have water on the inside of your airways. And water has high surface tension. So what does that mean to your balloon's ability to stay, to inflate, and then also to stay inflated or stay open when you start to deflate it? What does that mean if you have water on the inside? Harder to inflate, and then harder to keep them open because that wants them to collapse whenever you're not actually blowing them up. So we have a surface tension issue inside our alveoli too. Remember, water has high surface tension. Again. Now, it makes us difficult to inflate our lungs because the alveoli are collapsed. This is something that we see in birthing. When a baby is born, what kind of environment was it living in? Water. So it has all this amniotic fluid around it and inside the airways. The airways have never, ever been expanded. They are like a sponge that's basically collapsed on down and squeezed on down. And so now they come into the world, and we need to have a nice big inhalation attempt. And that's why we always like them to cry when they're born, because crying involves a bit of an effort. And that effort is required to get the air in because these are water-filled balloons. And the water will get absorbed into the capillary network, but we got to push it literally into the capillary network. So every breath they take, we get a little bit more expansion, and then again a little bit more expansion, and a little bit more expansion. And in order for this to work effectively for the newborn, they have to have enough of this present. Surfactant. Surfactant is a lipo, fatty protein that acts like a detergent in that it is designed to break down or minimize surface tension of water. And so those type 2 cells that are in the alveoli have to be producing enough surfactant so that when we put a little bit of air in those wet balloons, that when we're not forcing air into those wet balloons, they don't collapse. And the kids that don't have enough surfactant are our preemies, correct? So surfactant is a problem with preemies. If they have not had their lungs mature enough to where the type 2 cells have produced enough surfactant in that little water environment, that when they start to actually then put air in, they have no detergent-like stuff material, they just have water in there and their airways will collapse. And so how do we treat preemies that don't have enough surfactant? They're in more than just an incubator, because the incubator is just there to keep them warm. How's it going to keep their airways open? Yeah, they're on a ventilator. So the preemies that don't have enough surfactant being produced, they're on a ventilator because we are literally always trying to blow air in there to keep their lungs inflated until they produce enough surfactant. Now, let me explain how surfactant works. I want you to think of surfactant as in there with the water molecules, and the water molecules are very polar, but I want you to realize surfactant has a repelling polarity. Water molecules are polar and they like to attract one another, correct? That's what surface tension is all about. Well, I want you to think of surfactant as a molecule that is always repelling each other. And so if you put some surfactant molecules in there with the water and you have enough concentration, when the little air sac tries to get smaller and smaller, those little molecules will start to repel one another and keep the airway open and patent. Are you guys following me with this? That's how surfactant works. Surfactant pushes each other away. So it doesn't matter how, if you have them well inflated, it's no big deal. It's well inflated. It's when the deflation occurs to keep the airway open, if you have enough surfactant, it will not allow it to collapse. And that's how surfactant actually works. So we say it's a detergent-like material in the aspect that detergents definitely decrease surface tension. And so that's an important aspect. If I put surfactant into the lung cavity, into the pleural cavity, what would happen to our lungs then? They would also collapse because that's part of what keeps them expanded. So it's good to be inside the air sacs. It's bad to be outside the air sacs. Now let's take a look at some of the physics of breathing. Principles of gas exchange. Dalton's law. Total pressure in a mixture of gases is equal to the sum of the individual partial pressures. Partial pressures is defined as the pressure that an individual gas exerts in a mixture of gases. What this is trying to tell you is this is trying to give us a description of how we measure gas concentrations. So this is all a story about how gases are measured. Around us, this is what we have in our air. We have nitrogen gas surrounding us in the air around us that we are breathing in all the time. And it is 569 millimeters of mercury. Oxygen is 104 millimeters of mercury. Carbon dioxide is 40 millimeters of mercury. It's getting worse, getting higher. And water is 47 millimeters of mercury. When you add those all up, you get 760 millimeters of mercury, which is 1 atmosphere, which is the pressure that we are experiencing on us by the gases surrounding us. And this concentration, which is around us, is also inside us, correct? Do we use nitrogen? We don't use nitrogen gas. So it's considered basically an inert gas. It's just around, and it's in our environment. It's inside of our lungs, but we don't actually do anything with it. So it's not anything that we're worried about. We like this guy and this guy. And so we want to make sure that we're able to get oxygen in and carbon dioxide out. And so we don't want a high carbon dioxide environment if we want to get carbon dioxide out, because we will actually come to an equilibrium in a certain area of our lungs. And we'll talk about that in a moment. Henry, and so you guys have to memorize these people, their names. So these are some physics people that got their names out there. So Dalton, how we measure gases, and Henry, how gases, which are in contact with a liquid medium, how their concentrations can be assumed. If you have gases with those numbers and a liquid medium that they are on the surface of, you're going to have those gases actually dissolve in the liquid medium to the relative concentrations that you find outside. And so that's why in our notes it says a mixture of gases in contact with a fluid will dissolve in proportion to the partial pressures of the individual gases. And our blood is also liquid. It's got water in it. And so remember, interstitial fluid, what is that? It's liquid. It's got water in it. And so this is what we have to understand, that our gases are going to, in order to get oxygen to our cells, it's going to go through some water. And so we have to understand that with these laws, we can assume a lot of things about the concentration of the gases in the liquids and in the various areas that it's going to actually be transmitted to. So this is all about equilibrium or concentration of gases in blood, the liquid part, and interstitial fluid. We have two definitions of gas exchange, because now we're doing respiration. Respiration is gas exchange, and we have two areas of gas exchange. One is called external respiration, and the other is internal respiration. External respiration occurs at the level of our lungs. Internal respiration occurs at the level of our tissues. So really internal. Blood entering the alveolar capillaries. Is that fresh blood or used blood? Used. So entering is the key word. Blood entering the alveolar capillaries. So they're coming from the right ventricle. It's used blood. And our numbers reflect this. PO2, the concentration of oxygen is 40 millimeters of mercury, and PCO2, the concentration of carbon dioxide, is 45 millimeters of mercury. Well, out in the air, it's 104. And so now this used blood is, we've sucked a lot of oxygen out of our blood, correct? Is what this indicates. But what's really interesting is our PCO2 of our used blood is 45, but of fresh blood or fresh air is 40. And so as far as the amount of carbon dioxide differentials, it's not very big. What's really important here to actually understand, the one that regulates how we breathe and everything is carbon dioxide. It's actually not oxygen. It's carbon dioxide. And that's because carbon dioxide has a great impact on pH. And acidic pHs are not well tolerated. Our picture here shows the blood flowing in a pulmonary capillary. It shows you that it's coming in at 40 and 45 for O2 and CO2. And then once we're on the exit side of our capillary, which is actually called the venule side of things, our O2 is 104 and our PCO2 is 40. The cartoon picture that I had earlier, I'm going to go up to it, right here. I want to bring your attention to how the capillaries are around an alveolus. They're lacy-like or hairnet-like. The alveolus is a big structure compared to the capillary, correct? So it's like a big lake of O2. And so that little bitty capillary, as it's going around that alveolus, just one little portion of the capillary that's coming in at a PO2 of 40, will as it's going over that big ball of air, will go from 40 to 50 to 60 to 70 to 80 as far as gas levels, correct? Because it's getting O2 from the alveolus, right? And as it goes along, it will reach finally its equilibrium at 104. Now, that is a really big alveolus, and the capillary is really small. Do you think this is going to have a major impact on the O2 concentration of that giant lake of oxygen? It does not. And so that's one of the things that you have to keep in mind. We keep this number in mind all the time because this is a little bitty capillary going around this really big lake of oxygen. And so we're going to get to our equilibrium, and we will equal what's inside the alveolus, 104, once we finally get halfway through the capillary itself, actually. And this is simple diffusion. So oxygen is going from an area of high oxygen concentration to an area of low oxygen concentration. You guys follow that aspect? So it's still a simple diffusion process. Carbon dioxide is set at 45 when it comes in, and before it leaves, it's down to 40. And so it's going from high carbon dioxide concentration to low carbon dioxide concentration. But our lake is so big that it doesn't matter the exchange, because it's such a big collection of oxygen and high oxygen, low carbon dioxide. Our little skinny guy going through isn't going to have an impact on that overall concentration. And also, isn't this still connected to the outside world and being flushed on a regular basis as we ventilate? So that lake always stays pretty high there at that level. Alveolar gas exchange. Now this is our internal respiration. That above was alveolar gas exchange, excuse me. This is our internal respiration now occurring in the level of the tissues, and so we always have our interstitial fluid in this area. Interstitial fluid surrounds your cells. And so the gases are going to go from the bloodstream into the interstitial fluid and then eventually into the cells. Because isn't that what we did with capillary dynamics when we talked about it? We're always putting in fresh interstitial fluid and pulling out old interstitial fluid because that's what bathes the cells, and that's where the cells will get the good stuff and also put in the bad stuff, basically high to low concentrations. And so realize internal respiration is occurring in the tissues, and it's the exact opposite of what we just talked about for external respiration. In the aspect that CO2 is high here in the tissues, and we want to go ahead and lower our CO2 level at the tissue level. And so we will have the CO2 actually go into the bloodstream here, and you'll have the O2 go from the bloodstream into the interstitial fluid. So high CO2 into blood and low O2 from blood, eventually into the cell. Where does carbon dioxide come from? The cell. Does the cell ever stop making carbon dioxide? No. So where is the carbon dioxide concentration always going to be the highest? In the cell, right? It's always going to be the highest. So what you see reflected is the interstitial carbon dioxide concentration, and cells are always making carbon dioxide, always putting it into the interstitial fluid. And so that carbon dioxide concentration gradient starts at the cell, goes into the interstitial fluid, and eventually goes into the bloodstream to then be delivered to the lungs to go into the alveoli. Let's take a look at gas transport, how we actually move oxygen and carbon dioxide around in our body. It's really interesting. It's easier to dissolve carbon dioxide into the fluid portion of your blood than it is oxygen, which is kind of opposite of what I told you about with our proportion laws, but you still have to keep those proportion laws in mind. Oxygen is, less than 2% of oxygen is actually dissolved in the liquid medium of our blood, less than 2%. So we have to have a much better way of carrying oxygen around, and that's what hemoglobin is all about. Hemoglobin is designed to transport oxygen around in our body. And with hemoglobin, remember, we have 4 oxygen binding sites on each hemoglobin molecule. And that's the maximum a hemoglobin molecule can carry. So we can carry 1, 2, 3, or 4, correct? More often we are fully loaded unless we're actually coming from tissues that actually used up a lot of oxygen for us. You guys have done some of your PHYLS activities, and so you should actually already know this about how nicely hemoglobin will give up or take on oxygen. And so there's a word called affinity. Affinity means oxygen will take it up if we have a high affinity, and then we'll change our affinity based upon certain environmental situations, and we'll give up oxygen. And so that's an important thing to realize here. We're working with affinity. Higher temperatures, what does that do to the hemoglobin's affinity for oxygen? How much does hemoglobin like oxygen when it's in a hot area versus a cold area? Doesn't like it so much, which is kind of good, right? Because where is it warmer as far as hemoglobin carrying oxygen? At the level of your lungs or at the level of the tissues? At the level of the tissues. So where would you like to give up oxygen the most? at the level of the tissue. Where would you like to load up oxygen the most? At the lungs. That's all right, at the lungs. So you want to load up oxygen for hemoglobin at the lungs, which happens to be cooler than in the tissues. So this temperature differential definitely affects affinity of hemoglobin for oxygen. So hemoglobin has a higher affinity for oxygen at a cooler temperature and a lower affinity for oxygen at a warmer temperature. You guys follow that? Is lower at warmer tissue and vice versa. So it's higher at cooler tissue, which is perfect. We want hemoglobin to load up a bunch of oxygen when we're in the lungs. And we want hemoglobin to offload the oxygen when it's at the tissues. That's perfect. Now, acidity, pH. Where will you get more acidity if you are a lazy tissue versus a very active tissue? What will happen to the acid material or byproducts of the activity if your tissues?
Increase activity, increase.
Yeah. If your tissue is really active, one, it gets warmer too, doesn't it? If your tissue is really active, A, it gets warmer, and B, it actually produces lactic acid sometimes and carbon dioxide, because the higher activity of the tissue, the more carbon dioxide you produce. And one of the things I want you to always link in your head from now on, high CO2 means low pH. And so higher acidity or low pH means that this will have, this enhances O2 unloading from hemoglobin. So high acidity enhances O2 unloading, which is good because very active tissue that's metabolically active will be producing more acid byproducts, and we need, therefore, more oxygen for that active tissue. Here's another person's name you have to memorize, Bohr. So he noted that when you have a lot of protons around, this enhances the oxygen unloading from hemoglobin, because hemoglobin can bind protons. And this is good because it acts as a buffer. When you bind protons, you kind of take them out of the mix, and so that helps to minimize pH changes. However, when we bind hydrogen ions or protons, this causes a conformational change. In the hemoglobin molecule, causing O2 to be released. So conformational changes like a transformer. When hydrogen ions get attached to the hemoglobin molecule, it changes its shape and literally pushes off the oxygen molecules from its binding site. So that's what conformational change is all about. CO stands for carbon monoxide. Carbon monoxide poisoning is really interesting. Carbon monoxide poisoning is bad for you, right? That's why we have carbon monoxide detectors in our homes, because can we tell when carbon monoxide levels are high? No. Carbon monoxide is an odorless, colorless gas. And it binds to the very same site as oxygen. And hemoglobin has a higher affinity for carbon monoxide than it does for oxygen. What this means is that if you are in an environment where you have a little bit of carbon monoxide and a lot of oxygen, hemoglobin will go I want carbon monoxide. So it has a higher affinity. It wants carbon monoxide more. The other problem is it always has a higher affinity for carbon monoxide. So it doesn't give it up. So it doesn't matter if you change the pH of the environment. It doesn't matter if you change the temperature. The affinity is going to be higher for carbon monoxide. So that means if you're in an environment where there's a little bit of carbon monoxide, and as blood circulates on around, well, we load up with carbon monoxide preferentially once. We come back around, we're going to load up some more, right? We're just going to keep loading up no matter the concentration of carbon monoxide because we prefer it over oxygen and we will not let it go. Well, what does this mean then to the oxygen binding sites on the hemoglobin molecule? It gets covered up with carbon monoxide. Well, what does this mean for your cells? Oxygen deprivation, oxygen starvation. The interesting thing about carbon monoxide poisoning is it turns you cherry red. And you feel like crap because you feel headachy and nauseous and everything because your body's going, something's wrong. I'm not getting my oxygen, and it doesn't, and your heart rate's up and all this type of stuff because you're not getting the proper oxygen that you should be getting. And so when somebody comes in and they're really sick, and you look at them and they look really good to you, it will slow down the diagnosis on that individual, correct? Because you usually, in the emergency room, you only treat people that look really bad. And so carbon monoxide poisoning, that's one reason why we have carbon monoxide detectors. It's an insidious poisoning. And the person actually looks really, actually bright red because of the binding sites are all occupied now. Not even, let's say 90% or 95% of the oxygen binding sites in a normal person would be occupied by oxygen in hemoglobin, but now we have 100% binding of carbon monoxide whenever we have it in the environment. So you undergo oxygen deprivation. So how do you treat carbon monoxide poisoning? They do give you pure oxygen for it. And if it's really bad, they force pure oxygen, literally pressure it onto your hemoglobin molecules in hyperbaric oxygen therapy. So they'll put you into a pressure cooker and they'll cook you with oxygen. And they'll give you high pressure to literally try and force that carbon monoxide, physically force the carbon monoxide off the hemoglobin binding site. Crazy, huh? But that's if you're really sick. The most common way to treat it would be to remove carbon monoxide from your environment. Remember, the kidneys like to secrete a hormone called EPO, erythropoietin, whenever they detect low O2 levels, and so your blood will be thickening up as you make more red blood cells to then go ahead and load up properly with oxygen. So that's the way that you prefer to do that. So you don't turn blue with carbon monoxide poisoning, you turn bright red. Carbon dioxide is transported in the blood three ways. It's easier to actually get carbon dioxide into the liquid medium or the plasma. It is also bound to hemoglobin at a different area than oxygen, and that's why it's called carbaminohemoglobin when we have it there, and 20% of it is bound that way. And it's also transported around in your bloodstream in an ionic form as bicarbonate ion. That's the bulk of the way we do this, and we'll touch on that on Friday and finish off this chapter for our upcoming exam.